Okay, Aaron, are we getting close or,
Yes, it looks like the waiting room is cleared and it looks like Keith just joined us. So if all of our, and I do want to give we've been giving friendly reminders to all the TACs. All voting members must have your camera on while voting. If we can, for the purposes of the minutes and the transcript, if we can utilize the raising the hand so that we're not speaking over top of each other. And if you're not a TAC member or not speaking regularly, just identify yourself when you first speak. So that way the court reporter can capture who's speaking. So that way our minutes are complete. So that's all I have. The waiting room is being cleared out. So Keith, I will hand it over to you.
all right, thank you very much. I will apologize ahead of time. I just moved into our new house 2 days ago, and from a technology standpoint, I'm still getting all the bugs worked out. So if I drop out, I will get back on just as quickly as I can. Hopefully everything is going to go well. But just in case, I wanted to throw that out there. First off, thank you everybody for joining this month's meeting. See quite a few names on the list for today, so that's outstanding. Aaron, would you mind going and doing roll for us so we can establish quorum?
Absolutely. I have Keith,
Present.
Kevin, Linda. I thought I saw her log in. Okay. Dana.
Here.
Troy.
I'm here.
Joe. And Jacob.
Present.
Sorry, I am.
Oh, I thought I saw you log in. Okay, 1, 2, 3. That gives you 5. You have a quorum, sir.
Thank you very much. And I'm sending a message to Linda real quick and to see if she is planning on getting on or not, because today's discussion, we need to have as many people present as possible.
I thought I had seen her log in earlier. Let me scroll. Maybe she stepped away briefly.
Okay.
I don't see her now, so.
Okay, 1 second here. Let's see if she answers
Oh,
this.
no, I do see her, Linda Basham, 911 Billing Services. So it looks like she's logged in, but
Okay, great.
I don't see her on camera either. Oh, yeah, there she is.
There
I
she
see
is.
her.
There you are. Hey, Linda. All right, since we got everybody, we'll go ahead and start up here from item number 3, which is discussing the minutes from the April TAC meeting. I was absent for the April meeting. We had several people out and we actually did not have quorum. So therefore, I don't believe we have any official minutes to approve. However, we did get the transcript from the court reporter. As a point of order, I think we do need to go ahead and approve the court reporter's report. Since I wasn't able to catch that meeting, Troy, were you able to read those minutes and were you okay with them? You're on mute.
Yes, I was.
Okay, and everything looked good on them?
Yes.
From your perspective? Okay, so go ahead and call for a vote for the minutes from the April meeting. All those in favor of accepting the minutes or with any changes? Somebody make a motion?
Make a motion.
Second. Okay. All in favor, raise your hand, or actually we have to do the reaction by hand. So
I apologize. Whoever is A and B meeting, your camera was not on when you made a motion. I'm sorry.
That's Dana. It's okay.
Okay, thank you.
okay, so all in favor again,
Aye.
raise your hand. Aye. Very good.
Aye.
Any opposed? All right, no opposed. Motion carries. Minutes have been approved.
You may also approve your February minutes if you didn't have a quorum last or that.
Yeah, good point.
Yes. Sorry.
Thank you. No,
You're
no,
welcome.
thank you.
I
for
was on
pointing that
maternity
out.
leave, so I was trying to remember when that was.
Yeah, it's been a busy year already, no doubt. Okay, so going back to the February minutes, I have had a chance to read them. I didn't see anything on there. Hopefully everybody else has had a chance. Do we have a motion to accept the February minutes as written?
I'll make a motion to accept February minutes.
All right,
Second.
motion from Jacob and a second from Troy Walker. Any discussion? Okay, no discussion. All those in favor?
Aye.
Aye.
Any opposed? Okay, no opposition, motion passes. Again, thank you, I appreciate that. All right, going to old business. We have been discussing the issue of pre-authorization for transportation out of hospitals or healthcare facilities really since we started meeting in December. There's been a lot of discussion going on statewide about this. We were able to get a position statement from EMS providers about how the pre-certification process is harming EMS services. We had the discussion among the last K-Beams meeting, Kentucky Board of EMS open meeting. We discussed this, and the executive committee from K-Beams also discussed this issue. And the matter isn't so much that we don't want to provide information to the insurance companies. The problem is the current format with the form is not, it just doesn't work. It's asking for information that hospitals can provide some of it, but they can't provide all of it. And it's asking for information that EMS can provide some of it, but they can't provide all of it. It's kind of a nebulous form, and the fact that nobody can actually complete it satisfactorily enough to be able to get it to go through unless they've got a dedicated person that does nothing but pre-authorizations. If it is a ambulance service that's not fortunate enough to have office staff, or a hospital EMS service that's not fortunate enough to have case managers that have enough on staff to be able to do the forms, it's literally impossible. So what we're running into is that crews are having to try to get the information when they're picking up the patient, which it's not doing us any good, because at that point it's not considered pre-certification anymore. And it's putting us behind the power curve, and even when they do send it in, it's getting denied anyway. So in discussion with K-Beams, we discussed this at length about the issues we're running into and the number of EMS services that have voiced that they have issues with it. And we even sent out a questionnaire from K-Beams asking our EMS services in Kentucky if the form is causing issues amongst our services, so that we got a better representation from the field as to how the pre-certification is working, good, bad, or indifferent. And overwhelmingly, we have found that the current pre-certification form has had a very negative effect to the fact that the majority of our services, almost 75% based off of the survey, showed that most services have lost over $10,000 worth of reimbursement or more because of the pre-certification form issue. So we've been saying for a while that we would like to see the Medicare physician certification statement used instead, because it's a one-page form. It's information that our EMS providers are accustomed to seeing. Providers are accustomed to filling it out. They put down on these forms what the condition is requiring the transport. And it's worked for us with Medicare for a number of years. So with all of this being said, we would like to ask that all of our Medicaid MCOs, insurance companies, would please accept the Medicare PCS form in lieu of the pre-certification form. I just saw an email that came out last Tuesday saying that Aetna Better Health now wants the pre-certification form. Again, if there was a way we could do it and comply with it, and we're able to do it to provide all the information, I don't think our EMS services would have a problem with it. But the problem is we don't have that information. And most importantly, we don't have the staffing available to go out and get all this information, submit it before the phone call comes in for us to do the transport. And I see a hand raised by Dr. Cantor. So please go ahead, ma'am.
Thank you. I appreciate that. I was looking at the form, and UHC is not on the header up at the top. Where it
Yes,
says
on the PCS forms, it doesn't have any of the insurance companies listed on that particular form. So basically what happens is when the crews get these forms and get them filled out, they typically go to the billing company, which most EMS services that do charge for service do go through billing companies. We've got 2 of them represented today. We've got 911 billing, and we've also got A&B on board, which they are the ones who typically take those PCS forms for us and submit them to the appropriate insurance company. So Linda or Dana, if you all would like to speak to that, please feel free to do so.
Thank you.
So the form that he's referring to, the PCS form, is a standard form used across all EMS services. It's used by Medicare. So that's why there's no payer information on the top of that as far as who that's going to. It's standard just for patient's condition, where the physician can fill that out and state the need for an ambulance transport.
That helps. Thank you.
Thank you, Dana. And I would also like to offer the option, if the folks have not had the opportunity to see the document, the questionnaire document, we can, Aaron, if you could bring that up on the screen so we can go through it briefly, so everyone can see what the results of the questionnaire was in regards to the answers that the EMS providers gave us.
Absolutely. Me just a second. My screen was doing something a little weird a minute ago.
Sure, no worries at all. And while Aaron is getting that pulled up, just so you know, the questionnaire was basically 4 or 5 questions. It was very short. We wanted to keep it that way so that it basically wouldn't get into a lot of ad hoc conversations. It was to the point about asking specific questions. Mr. Owen, I saw you were asking a question there. Go ahead.
Yeah, sorry. This is Stuart Owen with WellCare, and we've got a work group that's been looking at this. The key thing is it'll be using the PCS form. It'll be a manual claims processing process, and so we have to set rules. It's basically claims team when the claim, because a claim comes in, from what I remember the prior meeting, claim will come in with a diagnosis. The physician, the PCS form basically has a physician attesting that the member meets criteria to be transported by ambulance. And so the claims processing team will have to look, is there a form, attached to the claim? Because I think that's what we talked about before. The claim will come in with an attachment. This form would be the attachment. And so they'll have to look to see, is there the PCS form attached? And then it has quite a few fields. And when I talked to the staff, it's like, well, does every field have to be filled out? And so that was kind of a thing we're a little bit wondering about, because I know there's the physician attestation, the physician describes the conditions, but there are other forms, other fields. And so they're wondering, well, if it's missing a couple fields, do we deny it because it's incomplete? But we are definitely looking at it, but that's what they mentioned to me, and they're definitely not opposed to that.
Mm-hmm. Okay, thank you.
Sure.
The issue that we're going to run into with having an electronic form being done before the transport gets done, again, is usually when EMS gets called to do a transport, we know nothing about the patient until our crews arrive at the hospital to get that patient. So any chance of doing a pre-certification, if you will, is virtually impossible unless the hospitals complete all of the form for us. And then the hospitals, they don't have the staffing set aside to be able to do that either, which, they've come to me and asked, who's going to fund the FTE to do all the pre-certification paperwork for EMS to get paid. And then that goes back to, well, then who's going to come get the patients out of your hospital, because we won't be able to do it because we can't afford to do it without the reimbursement. So it's a really, to use an expression, it's kind of an ugly baby that we got on our hands at the moment.
Yeah, and we were not looking at it as pre-cert. We were looking at just filing the claim with the form, after the fact, not as a pre-cert. Is this the vast majority of the scenarios going to be from a hospital to, either home or another facility? Is that like originating at the hospital, or are there other scenarios?
My experience has been out of hospital transfers, but let me open it up to the TAC and see what those folks think as far as the type of transports you folks are doing.
Me
And I
personally-
apologize. Oh, I'm sorry.
Well, me personally, out of the hospital is the main concern. Most of the time, nursing homes and things like that have case management and usually don't have no problems as long as they have a designated case manager at like a nursing home facility. Most of the issues we're having is from hospitals, especially ERs.
Thank you.
Aaron, you were gonna bring something up there?
I was just going to say, I'm having a couple technical difficulties, so I do apologize, but Kelly is also trying to work on getting the document. Oh, there we go. Thank you so much, Kelly.
Awesome, thank you. So on the screen
It
is
looks
the,
like Lisa has her hand raised with Humana
Oh,
as
yeah,
well.
go ahead. Go ahead, Lisa. Lisa, if you're trying to speak, you're on, there you go.
Now, this is Dr. Galloway from Humana. Couple of things. Clarification, when you say you all want to use this form, are you asking to submit this in lieu of having a medical necessity review?
Yes, ma'am.
Okay. In Humana, we currently do pre-authorizations, and we do accept the request up to 2 business days after the date of service. It's a grace period. So, you know, we do allow you to submit it after the fact and have the medical necessity review. You know, I think our biggest hiccup is not you asking us not to be able to do the review, because we do feel like they need to, you know, be reviewed for medical necessity and not just accept the certification form.
Okay. But that, if I'm understanding Mr. Owen's point, though, you all want it to be an electronic form and not necessarily a paper form. Is that correct? Or would the paper form be okay in that case?
Well, I can't speak for WellCare because I'm with Humana, but
No, I mean, I'm speaking on behalf of Humana. Would you all?
Well, as I said, we would accept the form, and it could be submitted with the other information when you request the authorization, which, like I said, we allow 2 business days after the date of service to be able to do the auth. We do not start applying our retro review criteria until after the 2 business days from the date of service.
Okay.
Keith, this is Dr. Brunner from Anthem.
Yes, sir.
Question, I know I do have, I know you're asking for a medical condition, but does Medicare require a diagnosis?
Yes, well, it's not necessarily a diagnosis. It's a reason that has to be indicated on the form for the reason of the transport. So if the patient were transported to the hospital with stroke-like conditions, but yet we have to transport because of unable to ambulate, then the crew would check that the patient was unable to ambulate as being the reason for the transport, not that they suffered a stroke. So the conditions for the transports are what's indicated on the form, but that's usually done by the provider at the time we're picking the patient up.
So we don't, like Anthem doesn't, we don't require prior auth for those codes, for those A codes for transportation, unless it's a out-of-network provider. So this would be, I brought it to our team, and their concern is to build a claim, there needs to be a diagnosis.
Okay, and would,
That's kind of the whole reason why we're doing this, though, is we don't have a diagnosis a lot of times when we're transporting. And the hospitals aren't required to fill it out. So until afterwards, till after the transport, we don't really have that. And by then, we've already made the transport, so.
Understood.
And we're in a catch-22 because we're not allowed to diagnose.
Yeah, so,
Sure, I mean, I'm just looking, so I was an ER doc in Northern Kentucky for years, and when we would send patients home, you had the discharging diagnosis on the chart, or at least an epic that could be pulled sometimes, and or the admitting diagnosis for an inpatient. Is there a way to get that from the hospital?
That's part of our issue too, is the fact that it's an epic. Our folks don't have access to Epic or to the hospital's paperwork. And honestly, as the patient's hospitalization goes on, let's say it's a patient that's a difficult case, as they go along, they garner different diagnoses codes. And if a crew or if a person looks at the wrong part of Epic, they may pull the wrong code, which then is going to get the claim denied because they used a code that wasn't the proper code. We're really in a catch-22, folks. I mean, I swear to the Lord, we're not trying to get out of doing work. We're just in.
Oh, no, I get it. Trust me. I've been on your side with this before as well.
some folks are able to get, at times, there are some ambulance services that have a ability sometimes to get some of those diagnoses off of reports,
Okay,
and Dr. Brenner, but a lot of them do not have access to that and can't get it, so.
And one of the other issues we run into is if the crew asks for a copy of that when they go to get the patient, then there could be a 20, 30, 40-minute delay at least for them to try to get somebody to get into Epic to get the information to be able to jot it down. And even then, it's going to be on a paper form again. It's not going to be an electronic format.
thank you, Troy. Thank you, Keith.
Are there any of the other MCOs that are on the line that have concerns about how we could go about doing this, or any suggestions? And then we'll jump into the questionnaire that we took with our EMS providers. Okay, hearing none, we'll go ahead and talk about the questionnaire. Again, the reason.
Kelly, I believe Dana has her hand raised.
Okay, yes, go ahead. I'm sorry, that my screen's pretty small. I didn't see it. I apologize. Go ahead, Dana.
Okay, that's what I'm here for.
That's okay. I just wanted to let the MCOs know that the PCS form that we are asking them to consider does have medical condition described on the form by the physician, and that's what the billing agency would use to code a diagnosis code for the claim itself. So it's not like the PCS form, or not having the pre-authorization, we're not going to have a diagnosis for the patient. We will have a diagnosis based on what the physician or the provider at the hospital supplies on the PCS form itself.
Would you think it'd be a good idea to get, I know there's quite a few requirements associated with the PCS form that Medicare has put out. Have we shared that with the MCOs, Keith?
We've sent a copy of the form. I've sent a copy to the state Medicaid office along with the instructions that came from PWW to be sent out to the MCOs.
Okay, good. Okay.
Yeah.
Troy, we have it.
Awesome. Thank you, Dr. Brenner.
Sure.
All right, Kelly, if you wouldn't mind going ahead and pulling up the questionnaire again for us.
Sure.
There we go. So the first page of the questionnaire was basically introducing the information to the services to be able to complete the questionnaire, basically saying why we are asking the information, basically the topic of the meetings we've had, along with the issues that a lot of services have run into with being able to get them completed. if you wouldn't mind, go ahead and scroll down to question number 1. Again, the form here on this particular page, I believe it's page 3, maybe. It doesn't have the page number on here, but it talks about all right, this is a copy of the actual MCO prior authorization request form that has been requested. This is a copy of the form that we have at Baptist Louisville. That's why it's that particular form on here. It's got the different areas on here that highlighted that has been problematic for EMS to be able to complete, such as the NPI numbers for the hospital. EMS does not have the NPI numbers for all the hospitals that we visit. Under the member information, we also do not know what the MCO ID number is for the patient. We don't know if it's a work-related injury or not. We don't know if the patient has any other insurance. The only way we know about insurance is if we have a face sheet that we get from the hospital for that particular patient, that gets included, and that doesn't happen all the time. In fact, our billing companies, it's not uncommon for them to have to go back and contact the hospitals to get the face sheets in order to get the insurance information to be able to bill the claim to begin with. And then down under the servicing provider information, most hospitals don't have the information regarding our EMS services, such as their address, the city, the tax ID number, their contact information. They just don't have that information. And a lot of the EMS crews, many of the EMS crews don't have that information for their own services, especially when it gets into what their tax ID numbers are or their NPI numbers. That's just not information that directors willingly share with the crews to be able to use for anything. And then down below is one of the biggest difficulties we have is the primary ICD-10 code that it's asking for. Again, that's something that the hospital would have to indicate. And again, depending on what part of Epic you're looking at, you're going to get potentially a different ICD-10 code than what could be potentially identified for the reason why you're transporting to begin with. That's why typically when the crews actually go to get the patient and they're getting the PCS form from the physician or from the provider, they're able to discuss with the provider what the medical condition is, and they can then have the provider indicate on the form what is the reason for the transport itself. Not why they were in the hospital, but what is the reason why we are doing the transport. Okay, go ahead and go next step, please. Okay, next. This is the actual PCS form. If you have not been able to see it, this is a generic copy that I got from Page, Wolfberg, and Worth law firm. They are one of the preeminent EMS law firms in the United States. Essentially, what we would be providing on this form is the patient's name, birth date, the Medicare number, or in your all's case, be the Medicaid number, the transport date, where we pick them up at, and where it's originating. It's a very simplistic form. In the middle is where it talks about the medical necessity. This is where the meat and potatoes of this form is at. This is where the provider is going to indicate what is the reason we need to transport the patient. Now, we know that this is not broken down by ICD-10 code. It's just not. To try to put the ICD-10 for all of these, it would have to be 2 pages long to be able to get all the data, or longer to have that added onto it. It's called out by its specific name, so the provider can simply check it. If we ask doctors to put an ICD-10 code, they're going to be just as frustrated as everybody else trying to get into Epic and find what the official ICD-10 code is, since there are so many ICD-10 codes. And then in section 3 is the actual signature of the provider who is saying that this is medically necessary. So you have the name and the position of the person who is validating that form that the patient meets necessity to go by an ambulance. And then underneath that signature is where they indicate what level of provider are they? Are they an MD, nurse practitioner, physician's assistant, registered nurse, social worker, case manager, yada, yada. That is what's indicated on it. It's a 1-page form. It's a very simplistic form for us to be able to get all the information that's needed to be able to bill Medicare. Now granted, we know there's differences between Medicare and Medicaid. However, if this form will work for Medicare, we'd like to see if it can work for Medicaid, and if it can't, where can we meet in the middle to make it work? Because we got to do something better than what we've got. Go ahead and go to the next page, please. Okay, so this was the first page of the results of the questionnaire. This was the license number of the ambulance providers that were providing answers to us. We wanted to validate that the people that were answering were actually authorized to be able to answer for their services, and that we didn't have services repeated in their answers. And it shows the date and time that they completed the survey. Next page, please. Just a continuation, we had 52 licensed ambulance providers that responded. We've got a total of about, I think, 260 EMS providers in the state of Kentucky. That number may fluctuate a little bit, but that was one of the last numbers that I heard. I got a text or a chat there from Dr. Cantor, and yes, ma'am, we will go ahead and send this out to you to where you can review it on your own computer. Won't be a problem at all. Next page, please. Okay, question 2 has the requirement for completing the MCO prioritization form effective to your ability to receive reimbursements since August 2022. 70% yes, 30% no. The majority of the folks that indicated no are simply no's because they either don't bill for ambulance transports, or by and large, they don't do non-emergency transfers. There is a great number of EMS providers in the state of Kentucky that have gotten out of the non-emergency transport. And speaking frankly, one of the reasons they got out of it is it's cumbersome. I mean, there's no easy way to put it. There's a lot of requirements to being able to document everything that needs to be documented. Now, granted, there are some unscrupulous EMS providers that have caused us to have to document everything as much as we do because of what they've done in the past. But by and large, there's a large number of people that have gotten out of the non-emergency business. We had them put down also their individual comments as to why they answered the way they did. It's going to be awful small for you all to be able to read. So after the meeting, Kelly, if you don't mind, can we email this document, actually the whole packet, out to all of the MCOs so that they have an opportunity to review all of this information?
I surely will.
Okay, thank you. Okay.
They should have received that already, but I haven't received it.
Okay. If you all wouldn't mind, if you did not receive a copy of it prior to today's meeting, if you wouldn't mind just putting in the chat that you did not receive it, we'll make sure that we send it out after the meeting. Okay, can we go to page 4, please? Okay, would you support using the Medicare PCS statement in lieu of the MCO prior authorization request? We had a 90, I think it's 96% said yes, 4% said no. And again, the people that said no because they don't do non-emergency transports. So by and large, it is a large amount of EMS providers that would like for us to be able to use the physician PCS form in lieu of the MCO prior authorization request form. Next page, please. This particular question was asking about how much revenue has been lost as a result of the implementation of the prior authorization form. Unfortunately, these numbers are very bad for EMS. We're already in a situation where we've got EMS services that are on the verge of closing their doors. And when we have some EMS services, in fact, 43% of them, or 14 of them that completed the survey, that are over $10,000 in lost revenue because of the prior authorization form, that's simply a call to action. We've got to do something because this is not sustainable in its current format. That's really the takeaway I have on this. And then there are some areas here where folks could comment basically off of what their answer was there. Okay, next page, please. And the page 606 is just the continuation of comments that were made by the providers. And I don't believe there was another page beyond that.
No, that's everything.
Okay, if you wouldn't mind, go ahead and pull the agenda back up for us. So that's kind of it in a nutshell, folks, as far as where EMS is regarding the prior authorization forms and the desire to use the PCS form. This is a difficult situation. And I would like to hear some more from the MCOs that are on the line about what your thoughts are after hearing what we said, after showing what we've been able to show. What is your appetite for us to look at being able to use the PCS form in lieu of the MCO prior authorization form?
Keith, this is Stuart Owen with WellCare again. I mean, we are definitely open to it. Would there be, because I didn't see like a deadline on the form, like maybe a 30-day, because we're talking about the, the service is rendered, transport is done, and then you file the claim in a form, like a 30-day window or something to file a claim in the form. If it's not filed within 30 days, and deny.
Sure. I don't think that would be a problem. Linda or Dana, would y'all like to comment on that as to what you all typically see? Your audio's dropped out on you, Linda. There you go. Oh, you're back on mute again.
Yeah.
Yeah, you're off mute now.
He's not picking up.
Yeah, you're inaudible, Linda. Your voice isn't coming through. Dana.
Linda, if you want to drop it in the chat, I can read it if you're having
Yeah, you
microphone
can.
issues.
Yeah, I don't read lips well, but I think she just said okay.
Zoom does not want to be our friend today, does it?
Not at all. Not at all. Yeah, while she's typing that response in, I really think Stuart, to your point, 30 days is more than enough time for us to be able to get those forms turned in. In fact, I think it's going to be quicker than 30 days. Troy, what has been your all's typical policy for getting those forms turned in?
Medicare already has that stipulation. You have to have it. That's why I was waiting to get the official Medicare number of days, what their maximum number is. Is that
So just mirror whatever Medicare's
21 days?
21. Okay. Thank you.
Wait a minute.
Linda said Medicare has told us all PCS forms for 21 days pending receipt of a signature.
Okay, and I think that's perfectly reasonable. If a crew gets the form, turns it in when they turn in their PCS form, really there shouldn't be a reason why it should go any longer than 21 days. Unless there's the extenuating circumstance of patient Jane Doe or John Doe that shows up to the hospital with no information. But those are outliers. That doesn't happen very often. So I think if we could adopt the same rules that Medicare uses, then that makes it much easier for everybody on our end to be able to keep up with what the requirements are. And if the MCOs were willing to do that, that would be absolutely huge.
Thank you. Appreciate it.
Well, thank you, sir.
And I think while we do that, Keith, I think it'd be smart because Medicare has regulations that require the hospitals to do their form. And while we're doing this, get the hospitals, Medicaid to get the hospitals, make them required to fill out these forms as well.
Sure. And then we got a message here, chat, about do we have a list of what EMS providers utilize third-party vendors to handle billing? I personally don't have a list, but we could probably ask everybody and get that back to you so that you all know exactly who does the billing for which services and who your point of contact would be for each of the services if a question were to come up. We'll do that and be happy to send that out before our next meeting. In fact, as soon as we get the data, if everybody's okay with us sending out information before meetings, we'll be happy to send it out as soon as we get the information. We'll send it to the state Medicaid office and have them send it out to the MCOs that are on the TAC list. Okay, and then Sean Collins asked, how is this handled in the commercial space? Dana or Linda, and I know Linda, you've got some communication issues there. If you all can address these, I'm not with the billing company, so it's hard for me to be able to discuss. So Linda put on here that commercial insurance does not require PAs normally.
Correct, Keith, there, but I guess the question is, are you seeing claims denial for the same reasons with Medicaid as you would with commercial? Like you know, like I said, we don't require PA for those A codes. It's just it's what happens on the claim side. But I guess the same question, like, you know, Sean's with Anthem. What are you guys submitting for claims payment with commercial patients and members?
As far as authorizations or anything, there is nothing that is submitted to a commercial payer. You only submit the claim with the level of service, the mileage, and the diagnosis codes.
So the commercial requires diagnosis as well.
Yes. Every claim would require a diagnosis.
So
code on it.
what are you submitting, I guess, to the commercial plans to get that? Are you like, is there a specific form, a separate different form for commercial?
I guess I'm not understanding your question because there's really not any forms that we file claims electronically. There's no forms that are attached to a commercial insurance claim. It just goes out with, again, the diagnosis code we're getting from the PCR once the transport has been completed. After the patient's, there's a chief complaint that is called in when the transport's requested. And then based off of the observations of the EMS provider, listing out, you know, the condition of the patient and different readings, then the PAC certified coders would code from that information in the chart, just like a coder inside a physician office would code from a chart after the patient's been seen.
And then Linda also followed up pretty much saying the same thing you did, Dana, that they submit the medically necessary reason code and that they file electronically as well, to where there isn't an actual paper form on that side.
So the smaller EMS providers they're also able to file electronically.
Typically, most of them all have billing companies that do that for them.
Okay.
Most, and I can't speak for everybody, but most every EMS service that I have visited over my years, none of them bill internally. They all externally hire billing companies to do it for them.
Okay.
And there have been a few services that have come to us that done internal billing prior to being with us, but they've also been able to submit electronically. Just doing it internally, you would just contract with a clearinghouse in order to submit your claims through. Most billing software allows electronic claims nowadays.
This is Stuart Owen with WellCare again. I was thinking it might be helpful to have one template that we all used. I know we've got the Medicare form, but maybe kind of customize it for Kentucky Medicaid. I don't know. That would probably make it easier or more,
Yeah, to your point, Stuart, I think if Medicaid said, no, we have to do something that add a little bit more information, if we were to come up with a custom form that our crews would be able to do in the field with them, I think that's something we could sit down together and potentially come up with to be able to get that additional information, but make it to where the crews have time to be able to do it and can do it to where it's not asking for a whole lot of information, or it's not asking for data that they simply can't provide, such as the NPI numbers, tax code numbers, information like that. And if we could sit down and potentially build that form together, as far as EMS providers and Medicaid providers, that would go a long way as well.
Yeah, and I mean, I don't think it would take much revision at all, but maybe just, I was thinking a couple things or whatever, make it clear. It's like Kentucky Medicaid, whatever tweaks need to be done. I was thinking.
Sure.
It would be great to have one form that done it all, but I'm just going to be honest with you. If it took a Medicare and a Medicaid PCS form, I'd be all in just to get away from pre-authorizations.
Troy, Keith, this is Sean at Anthem. Are you guys aware of any other states around us like Ohio or West Virginia that are they dealing with similar issues, or do they have like a potential fix that we could kind of create that template? I agree with Stuart. WellCare, that's kind of where I was going down the road of is it sounds like we need one consistent template to make your life easier. I think there's been we're creating some issues unintentionally, of course, but I think we've got to come to a resolution. So I didn't know if you all had talked to anyone in your circles and around Tennessee even that may have a solution that they utilize.
No, I have not specifically spoken to any of the other states. Linda did answer that not all state MCOs are requiring PAs. I think that's if how our EMS rules and regulations differ between states. I can tell you that it's usually dramatic. I can't imagine on something like this, though, it would be hugely different. But my guess is everybody does something a little bit differently. But we can certainly reach out and see what the other states do. But I'm liking the direction that Stuart suggested. If that's what we need to do to get all of the MCOs on board, and that we're able to satisfy what the insurance companies need, and we're able to satisfy what EMS providers are able to provide.
Yeah, I agree. I think Anthem would agree as well. So
Yeah,
we'll reach out on our end and see if any of our sister markets, how they're kind of approaching this too, to see if there's anything unique.
One of the things we've noticed on the air side, and sorry guys, but we've noticed that Indiana and Tennessee seem to be as far as closer aligned with what we move towards in Kentucky than we're seeing any other of the adjacent states, if that helps anybody in one direction or another. But as far as like some of our payer, sources and reimbursement rates and different things. So if that helps, I think Indiana was primary, and then Tennessee was right behind them on some of the changes we're seeing.
Okay, thanks, Josh. That does help. I'll reach out to Indiana and Tennessee, at least from an Anthem perspective, and see if they can.
Dana or Linda, I know y'all both have clients outside of the state of Kentucky. Is there a certain form that any of those use, or is it just pretty much they do have pre-auth or they don't have pre-auth? I didn't know if y'all could enlighten us on any forms that they might have.
It is a state by state requirement, and they all have their own ways of verifying or getting pre-authorization. Some are, online, some are paper. It just depends on the state and the actual payer.
Do any of them use something like the PCS form, like what we're proposing?
I don't know. I would have to check with the other teams to see. And she says she's not aware of any. Linda does. So I didn't think there was, but I would check with the actual billers to make sure that there wasn't something new that had come on. But no.
Okay, muted myself and didn't realize it. Are there any other comments that anyone would like to make? Okay, very good. I think we had some really good information going back and forth on that. I appreciate everybody's input on it. Why don't we form a small group of MCOs and EMS TAC members to be able to discuss a form that both can work with and be able to establish going forward, because it sounds like the Medicare PCS form, straight up as it's written now, may not check all the boxes or some of the main boxes that Medicaid needs, but perhaps there's some small tweaks that we can make to add to it, to where our EMS crews can still get it done and be able to meet the needs of the MCOs and our providers. Do we have any folks that would like to agree to work on that together?
I sure would.
Okay, Troy?
Keith, I'm going to check on that because it's TAC business. It may have to be discussed in an open meeting, but Leslie, are you on? Is that correct?
Yes.
Okay, so that does need to be discussed in an open forum, correct?
Yes, as far as I know.
Thank you.
Then would it be appropriate if we could schedule a subcommittee meeting where it could be open, but yet not necessarily during the actual TAC meeting, the
Yes.
entire TAC meeting?
Yes, sir. What you can do is you can call an emergency meeting. And what you do in an emergency meeting is we'll get together, we'll schedule a date, and it runs very much like your TAC meeting. Only with an emergency meeting, you're only allowed to discuss items on the agenda. So there's no general discussion, recommendations, things of that nature. So you can only discuss what's on the TAC agenda, and we can call a special meeting for that. That is the option for that. Yes, sir.
Okay, great. And Dr. Cantor has agreed to meet as well.
Yeah, this is Stuart with WellCare. I definitely agree as well.
Okay.
And
awesome.
Keith, you and I can get together with some dates coming up. I believe your next one is at the end of August, so maybe sometime mid-July-ish. We can look at some of those dates to see. So it's kind of in between your two TAC meetings.
Yeah, actually, if there's a way we could step it up and even potentially do it before then, not necessarily the week of July 4th, because there's a lot of people traveling then, but maybe right after that, because this issue is major for EMS, and we need to try to get this handled as quickly as we possibly can.
It looks like we do not have a TAC meeting that would conflict on Monday, the 10th from 2 to 4, and that keeps it on a Monday in your all's normal time slot. But we can discuss that offline, and I can get all
Sure.
that information out to all the MCO partners and all the DMS staff as well. So we don't eat up all your time here.
Awesome. That would be fantastic. Thank you so much.
You're very welcome.
All right. Well, thank you all very much for discussion on that. And sounds like we're moving in a positive direction. All right. Does anybody else have anything from old business that we need to discuss that I may have omitted from the old business as part of the agenda? Okay, we will go ahead and jump over to new business, which the only item I have under new business at this point in time is the potential to update the payment grid for EMS for Medicaid transports for the next legislative session. In the last MAC meeting, it was encouraging to hear the Medicaid adjustments that were being made for such things as dental, vision, and other areas. And we had talked before about, and some of the legislators had worked with Commissioner Lee, looking to potentially make a positive change in the Medicaid reimbursement for ambulance. And just curious, with the new session coming up and with it being a funding session, has there been any discussion, whether through Kentucky Medicaid or through any groups that anyone is aware of, where the issue of EMS funding can come up? Because with us still being reimbursed for non-emergency under the T2005 at $55 a run, you know, our average cost per transport with a BLS crew is $78, and that's for like a 45-minute run. So we really need to look at the non-emergency, especially the reimbursement. Obviously with the GMAT format or GMT program, there's some opportunity for EMS to be able to get some additional dollars in to be able to pay for those transports, but not all EMS services are able to benefit from the GMET program. So with that being said, is anybody aware, especially on the Medicaid side, if there's any pending litigation, discussed litigate or legislation, not litigation, my mind's in the wrong spot there, having to do with reimbursement for EMS?
Keith, this is Leslie Hoffman, and I don't want to speak for Justin specifically about any payment or reimbursements. I was actually going to give you an update today on some other things that we've got going on, but it is my understanding that they are currently right now looking at ways to reimburse based on House Bill 8. I believe that's what she said. So I don't have any specifics unless Justin does, but it is my understanding that they're working towards that.
Yes,
Okay.
this is Justin Derringer, Leslie. That is correct. There are studies currently looking into different reimbursement methods based on that House bill.
Okay, and House Bill 8, that is the GEMT program. Is that correct?
Justin, do you know? I'm not sure about that. I know that was related to.
That's not the same program.
Okay.
Okay.
So they're looking at reimbursements for all providers, I think, through House Bill 8 right now. And this is one of the groups that the information came up. So I just wanted to let you know, and I can't speak to that today because Commissioner Lee's not on. But I do know that they are evaluating that currently right now. So that's a positive, not a negative.
Absolutely. Yeah, any talk we can do is a good talk. So
Now, Keith, do you want me to give you an update on the things that I had today? I thought we needed to give you an update. I think Leanne Fitzpatrick maybe has come to you in the past. I'm going to share my screen, and I'm not going to go through all of it. I promise. There's a lot of information here. There's a lot of moving parts. I would suggest if you have any questions, just to reach back out to us with an email, and then that way I can make sure that you get the information timely.
Sure.
Let me
that'd
see.
be outstanding.
Can you see my screen okay?
Yes, ma'am, just came up.
Okay. So I'm Leslie Hoffman, I'm Deputy Commissioner for Department of Medicaid, one of the Deputy Commissioners. And I've also asked for my Myers and Stauffer consulting team to be on today. Just as there's so many moving parts, I want to make sure that I have accurate information related to questions because we've got lots of initiatives that we're working on. And I'm going to leave it in this mode if you don't mind, in case I need to go back to a screen. I should have it big enough where you can see it.
Certainly.
So treat in place, treat no transport. We have a state plan amendment that has been drafted and is finished and is currently under DMS review and approval process to be sent off to CMS. We have an anticipated date of early July, maybe this week or next week. I'm pushing Aaron on that one. Anticipated effective date would be January the 1st of 2024. So just give you some information. EMS providers may, if this is approved by CMS providers may bill for Medicaid for medical services rendered at the scene of a call that does not result in the patient transport. So these are things that we're currently working on. And all this really started coming about with our mobile crisis. So you just bear with me. I've got like 4 things to get through. And then if you got questions, we can go over those a little bit later. Medical services must always be appropriate, medically necessary. This would be billable under the HCPCS code A0998, which would be added to the Kentucky Medicaid Transportation Fee Schedule. Reimbursement would be linked to the existing A049 BLS, and that is the BLS, sorry, I'm just making sure I've got that right. Base life support, I was looking at that, which is 8250, but any future changes that may come about to A0429 will mirror A0998. So what that's saying is, if in the future, those two that are connected rate increases occur, then they'll both be reevaluated. If it's a treat in place and there's no transport, then there's no mileage for reimbursement, of course, for your transporting. The expectation is that the MCOs will follow the fee-for-service methodology. That is in the future. Remember, we're looking at January the 1st. We would work with our MCOs that are on the line today and ensure that you have ample information and timeliness to make those things occur. So again, this is treat in place, treat no transport, and I think this was part of House Joint Resolution 38. I believe that's right. So that was part of that as well. But again, we were already working on these things, so that was good that we were already doing that. So
ma'am,
this is, I'm sorry.
Leslie, real quick, just a quick question on
Yes.
the treat no transport. Would mobile integrated healthcare or community paramedicine, would that work under that to where if we send a medic to a person's house to do a well care check on them because of a complaint or a checkup request, that would be covered if the patient is a Medicaid patient?
If that is a behavioral health transport related to mobile, Bradford, are you on? I'm correct, right? I want to make sure that I'm saying that right.
Yeah. Hey, this is Bradford with Myers and Stoffer.
Just making sure I get it right.
I think the intent of this is for, if you're called out to a home, maybe there's a diabetic patient, or if you're called to a scene of an accident and you perform some type of medical treatment on the scene and there is no transport, that it would be used in those cases.
Okay.
Sorry,
All right.
I'm going back. Sorry, Keith, you were talking about the treat in place. I thought you were talking about the behavioral health piece. I'm
Oh,
sorry.
no, you're good.
Yeah.
You're
No,
good.
you're fine.
And again, this is Justin Derringer, just to kind of clarify what Deputy Commissioner Hoffman said. Anytime that a individual from the EMS service goes out to do the evaluation process, that is, will, under this state plan, will be a billable service. So in the scenario you just asked, it would be billable to Medicaid.
Fantastic. That is awesome.
Now, remember, all of this is pending CMS approval, and they may change it. They may say, I'll agree to part of this, but not this, or you've got to negotiate, we have to negotiate with them.
Right, right.
So this is the second part. Lots of moving pieces. Like I said, this is our behavioral health crisis transport, or our BHCT. This state plan amendment's already been drafted. We've reviewed and approved it, and we submitted to CMS last Friday. Our anticipated effective date for this one would be October the 1st. The new provider type, a BHCT, would be a provider type 59. So providers that are interested in being this type of provider would of course have to go through all the proper procedures to be able to engage with this provider type. The intended use would be to transport of recipients of mobile crisis intervention to 23-hour crisis observation stabilizations, residential crisis stabilizations, and residential or inpatient hospital. Just stop 2 seconds. The 23-hour crisis observation and the mobile crisis changes are in a SPA that were actually submitted in April, and we are on the clock with CMS. So that one's already been done. The BHCT specifically was completed on Friday and sent to CMS. So we've got lots of movement going on. The transport between facilities, including but not limited to transportation from emergency room departments to behavioral health crisis treatments, including that 23-hour that we are developing for mobile crisis, residential crisis stabilization units, or inpatient psychiatric hospitals like Next Level of Care. Provider eligibility requirements. Now, again, we don't have all this worked out, so I'm just trying to give you as much as I can. Provider eligibility requirements meet transportation requirements in existing KARs and other state and federal transportation requirements. The vehicles have to be staffed by at least 2 employees, a driver and a staff person. We would want this provider 59 type to be available 24/7, 365. And there would be annual training requirements related to de-escalation, behavioral health, and at least CPR training. This goes a little bit farther. Our behavioral health crisis transport would be to the nearest appropriate level of care is billable and must be via a vehicle meeting policy specifications. So there's some things that we say that the vehicle must have. This would be billable under HCPCS codes. The base is T2003 at $80 a trip, and then plus mileage at a A0425 would be $2 a mile, following the existing rules and the fee schedules and all those kinds of things. If EMS is acting as a BHCT, they must meet the BHCT vehicle requirements to bill the BHCT. So I just want to make sure that they understand that we'll have, for that provider type, there will be separate provider requirements and also the vehicle requirements. A provider who is both a BHCT, and I'm sorry about all the acronyms, and provides mobile crisis intervention services such as the mobile crisis team may not bill for the BHCT in addition to their mobile crisis services being billed at the S9484. So I know that's confusing, but it'll get clearer as we go along. This is still a lot of it is new to folks. Vehicles must include separation between the driver and passenger. The passenger compartment must have at least 2 traditional vehicle seats with seat belts, be free from all sharp edges, equipped with doors that automatically lock, and they're not capable of being opened while the vehicle is in motion or in drive. BHCTs will be required to comply with all data reporting to the state. Everything that I've got going on related to mobile crisis, there is a huge requirement for all these outcomes, data measurements. So there will be a requirement related to data reporting. And I just wanted to make sure that you knew that. Alternative destinations, Medicaid's currently exploring options for EMS transportation to destinations other than EDs. I believe, Justin, this would require a regulation change. EMS transport to approved non-hospital destinations such as crisis stabilization and would be limited to medically necessary low acuity patients. I just wanted to make sure we've talked about putting this in here. This is not supposed to ever be a substitute for non-emergency medical transportation. So we don't want it to be that method that everybody just starts using because it's available. It's not a substitute for the non-emergency medical transportation.
Leslie, there's a question
Oh,
in the
I'm sorry.
chat from Paul Phillips. It says, am I understanding that 4 personnel would be required on the BHTC vehicles?
I think that's
It would be 2 people.
Yeah, only
Staffed with 2. One of the individuals being the driver and the other a support staff person.
Okay.
And we will email this presentation
yes.
out to the TAC members.
Yes, I was literally updating it seconds before I got on today. So Aaron, will send this to you.
Thank you, ma'am.
I wanted to share just a little bit about mobile crisis. And again, I'm not trying to keep you all on here all day, but I wanted to share just a little bit so that you're aware of what huge endeavor that EMS could be a part of if they're interested in being a BHCT as well. So we had, you probably heard me speak about this if you've attended any of the MCO forums or any of the other TAC meetings, those kinds of things. We applied for a planning grant. We partnered with our sister agencies. We said, how do we fill in gaps, knock down all these walls, come together? We've blended funds. Like I've never been so not just blended financially, working together, all of our partners that came together to work on this, to develop one all-inclusive crisis continuum. So that's what we did in September. We developed that planning grant, took a year. January through March, we had stakeholder engagements and lots of research, literally 3 months, boots on the ground, talking to folks about what works, what doesn't work, where are the gaps, how can we help, especially in our rural communities. In April, we developed the needs assessment, and that's the link that's over to the left. I'm not sure if that's your left underneath the diagram. I don't share that because it's over 250 pages long, and that's what we utilize to drive all the choices and changes that we've made going forward with mobile crisis was from that 250-page document. We designed and developed a couple of models. You'll hear us talk about this. It's a Commonwealth model and a community crisis co-response model, and those are complementary to each other. So we want those to work together. I've never seen this done in any other state, this community co-response model and all the opportunities within the co-response. This administration has done an awesome job to develop something very specific for Kentucky's needs. So January to March of 2023, we started working on the co-response stakeholder engagement and research. March of 2023, Governor Beshear announced our proposal that went out. And then in May, Governor Beshear also announced opportunities in our CCCR model and upcoming funding opportunity. And that's something I wanted to mention as well. So that's our community crisis co-response model. I'm trying to remember the acronyms myself. We will have a governance and oversight for this mobile crisis intervention model. And we will have those two models I talked about that are complementary of each other. We will have 4 regional service areas, which we will call RSAs, to serve as the Commonwealth model. And we will be introducing the CCCR model to increase access and availability of services. I'll tell you a little bit more about that.
Still in process.
Just a second, please. Sorry, got another meeting going on here. So our key outcomes to develop complementary models. You have the Commonwealth model, which is the 2-person mobile crisis team, which is comprised of at least 1 behavioral health practitioner and a paraprofessional that would be available 24/7, 365. That is dispatched primarily through 988 and local crisis call centers, response in person at the location of the individual. We also have the our co-response CCCR model, which is our CRU unit, which is comprised of law enforcement or first responders with a behavioral health practitioner, paraprofessional, or peer support. Availability may be based on local needs and resources, and dispatch primarily will come through 911. This will arrive during the active situation and provide follow-up services after the situation has been resolved. And I'm giving you a lot of information today, and I'm not going through all of it, I know. The main piece to this is that we want to come together, divert from jails, hospitals, and emergency rooms. We want to build a comprehensive continuum using SAMHSA's national guidelines. We want them to have someone to talk to, someone to respond, and a place to go. This is a behavioral health crisis service for anyone, anywhere, anytime, with no wrong door. I'm just trying to explain to you all that we want EMS to be a part of this if you're interested in it, and to help us with the access and services. So someone to talk to would be 988 regional crisis call centers, public safety access points, which is PSAP, and 911. Someone to respond would be regional mobile crisis providers. We're looking at CMHCs, CCBHCs, and BHSOs. We are also looking for a special model that's called MRSS for Children, which is out of Maryland, and it has an extensive follow-up, about 8 to 12 weeks of extensive follow-up. Community paramedicine, co-response and law enforcement, prevention, deflection, diversion, and inclusion is what we want when somebody responds to these members in crisis. And we want the members to have a place to go with least restrictive next level of care, 23-hour short-term crisis observation, first responder drop-off options, and post-crisis follow-up. If you've recently seen any of our Twitter, Facebook, or any other social media, Instagram, we have posts that have buzz that are promoting our CCCR messaging, press releases, and announcements. And there's an embedded video there if you are interested in that. So one of the things that you will see is a CCCR model funding opportunity. And this is where July of 2023, we will be releasing a NOFO, which is a notice of funding opportunity. And again, I've never done this before. The cabinet will be actually offering a NOFO to community municipalities, city government municipalities that want to develop a crisis co-response model in their area. So this is very, very exciting. And I think the governor also announced that as well. Just one more thing that I want to throw out there is that Of course, I serve as Medicaid's, one of Medicaid's racial and health equity champions. We currently now have just recently a division of population health as well as a branch for racial and health equity. But everything that I explained and went over today, I wanted you to know that we've done it through the lens of cultural humility, and that anything going forward that we're constantly working on through racial and health equity. I did just include, I'm not going to read over all this, but one of the main things for you to know is that Medicaid has all these racial and health equity initiatives that we're working on. We have a particular tool that we utilize. It's called the GARE tool. And through the GARE tool, we run programs or projects or tasks through the lens of culture humility. And we are using mobile crisis kind of as our use case or our model for Medicaid. And so it's like a living document. Every time we change or add something, we go back and make that into the, we incorporate that into the living document. So for example, because we want EMS to partner with us and we want to increase access, especially into these local and rural communities, that will go into our GARE tool. That is something else that we are moving towards. This is just to let you know what the Medicaid Collaborative is. If you want to read about it later, we are participating that Iowa, Kentucky, Nevada, and New York. These are the emails that I said. If you have questions, just send it. If you send it to the DMS issues box, that would be fine. It's dms.issues@ky.gov. And if you will just title it, something related to EMS or mobile crisis, then I'll make sure that the correct SMEs, our subject matter experts, get that picked up. If you want to see anything related about the mobile crisis initiatives or other behavioral health initiatives we've got going on, there's the DMS webpage. And then, that's the behavioral health webpage that we designed last year. And then we have, of course, the DMS homepage. You're always welcome to email me. I'm leslie.hoffman@ky.gov. And then, of course, questions. I know I took probably, Keith, more time than you wanted me to explain.
No, I appreciate you going over
I
that
want
because-
you to have it, though. And then if you look at it and you have questions, we'll keep participating in your EMS TAC. And then that way we can keep you apprised as we're moving along. I will say, I always say this with new programs and ones that are this large. This is the largest project I've worked on in my 27-year career. This is the most intense, multi-level spider web. I don't know how else to explain it. So it's easy to get lost in the middle, and it is even for us. We've got 3 SPA changes and a regulation change that we're all working on right now related to things. So it's very easy for us to even say the wrong acronym, right? But I want you to have this information, and we appreciate everything that you all do.
Sure. And I think it's good for us to have this because any type of behavioral health transfer or transport, we do usually get right into the middle of it. So please don't feel like you have to apologize for taking so much time because it is vitally important for all of our providers to be able to understand what changes might be coming down the road for us because we do our fair share of the behavioral health transports. And to that point, we've got up in this direction, one of our hospitals in Louisville is getting ready to expand to take on more behavioral health beds. And there's several others I've heard of that are about to do the same. So behavioral health has definitely starting to get the attention that it is needed. Now, if we can get our providers protected during some of these encounters, because it's not uncommon for some of these folks to act out and to throw hands in the back of ambulances. So if we could find a way through de-escalation techniques that are effective, that would be phenomenal. Now, what I did have one question about, you showed the billing rates for Medicaid patients. If we have to respond, once all this gets into place, do you know if commercial providers are planning on stepping up and providing any type of benefit for their customers, or is this strictly going to be a Medicaid initiative?
So far, what I've been working on is Medicaid. I can't speak for the MCOs or what they might do on the commercial side or in other areas, but what I've been working on has specifically been for Medicaid. Again, we've got a lot of moving parts here, and I think the best thing for us to do, and I said a lot and I talk really fast, I'm sorry, is just to keep you apprised of where we are and what we've got going on. And I always say, you know, something of this magnitude, will it have gaps? Sure. Will we find problems? Sure. It's part of growing pains, and this initiative is huge. So my behavioral health team within Medicaid, of course, is partnering with Justin Derringer's group also in Medicaid, and we're working again. Collaboration is so key with tons of projects that are going on right now. Department of Behavioral Health, DCBS, Department of Community-Based Services, DOC, DOJ. I mean, we're working, DJJ, we're working with all of our sister agencies right now to try to fill in the gaps to meet crisis needs. So yeah, this is very exciting. And like I said, even us trying to pull in EMS and trying to make some things happen with your group also increases access and meets some racial and health equity needs, and also workforce needs that you all may have. So hopefully we can all partner together and make Kentucky better, right? Have more available resources.
That would be outstanding, especially on the part about finding resources to be able to respond, because we are getting critically low on EMS providers across the state of Kentucky, and we've got to find something, some carrot to use to encourage people to come into the industry. And it's going to take more than just EMS people thinking about what it's going to take.
Sure. And I would suggest that you take a look at the NOFO that's coming out, maybe not necessarily you, but your local areas or city governments, municipalities that might be interested. It's kind of what you just said. We were trying to offer a carrot to help entice folks to get going and to meet a higher level of quality and need and clinical need if they need it. So yeah, I would suggest you do that. And I'll send this PowerPoint to Erin, and then she'll send it out to everybody. Okay.
Outstanding. Deputy Commissioner, thank you so much for presenting that. And I'm looking forward to reading it all again and digesting it.
Sure. And like I said, me or one of my staff, I think Leanne Fitzpatrick has been on with you all before. Make sure that we keep you updated as to where we are with the spas and regulations and things like that.
And Leslie,
yes,
my goal is to have the treat in place submitted by the end of the week. Thank you.
Can you get it done before 2 o'clock today? I would love to exceed their expectation.
We tried.
I would try. Okay. So anyway, yeah. So we'll keep you apprised of what's going on, and I'll send the PowerPoint out once I drop off. So thank you so much.
Oh, thank you.
All right.
Very much.
All right. Bye-bye.
Bye. Are there any other comments or general discussion points that anybody would like to bring up? Okay. If not, moving on, is there any formal recommendations that the TAC would like to take up for consideration to go before the next MAC meeting next month? I don't think it's necessarily a recommendation, but I think that a briefing to the MAC is appropriate for letting them know where we're at and working together to come up with a useful form that both EMS and the MCOs can come together on to be able to use moving forward. And I think that that's a good thing. I'll be happy to brief the MAC about that. Number 8, MAC meeting representation. I'm going to be 100% honest with you all. I don't know what I was thinking when I put that on there, and I am drawing a blank as to what that even is, other than the fact that there is a MAC meeting that occurs in our off months that we're not meeting. Everybody is welcome to sit in on it. It's usually scheduled for 2.5 hours and goes 3.5. So pop some popcorn and have a drink if you're going to attend it, because it can get rather long.
Keith, we put that on the agenda as a template, just so you can, if no one from your TAC is going to be there when they're going through the TAC updates, I can just let the chair know. So
Okay.
we're not just sitting there in silence. So that's all the only reason that we added that to the template. You don't have
Okay.
to keep that on your agenda if you don't want to.
All right, thank you, because I was really, when I looked at that a minute ago while I was talking, I'm like, oh my gosh, I don't know what I'm supposed to talk about here. Sorry about that.
No worries.
Okay, so our next meeting is August 28th from 2 to 4. Obviously, we will have a special call meeting that we will get the word out so everybody is aware of it for July 10th. So if everybody could pencil in July 10th from 2 to 4.
Keith,
yes.
if that's a go, I can send the calendar invite right now. I've already got it prepped and ready to go.
Yeah,
I'm just waiting on the official call.
I think we need to do it. If there is any opposition to that date, please speak now, forever hold your peace. I think this is something that is extremely important and we need to move as quickly as we can on it. All right,
Invitation was sent.
awesome. You're fantastic. Thank you very much.
Well, thank you. I try. If you can just get me an agenda ASAP so I can share that with our MCO partners and DMS staff. I'll get that out and on the agenda and I'll get our website updated with that date.
Fantastic. I'll be happy to do that. Okay, we do have a message here that Aetna Better Health does have a conflict and will not be available on that particular day.
Is that everyone with Aetna, Wendy, or just you specifically?
I believe it's going to be everyone with that. No, we have our NCQA audit that day,
Oh, okay.
the 10th and the 11th. So we'll be tied up.
Okay, do we want to still move forward with the 10th or do we want to look at the following Monday?
The
I'll stop
17th is clear, so that would be your call as the TAC.
From our EMS folks that are on the call still, does anybody have any objection with moving that 1 week to the 17th so that we can accommodate all of our MCOs?
17th works better for me.
No problem here.
Okay, Joe, are you good on July 17th?
I'll make it good.
Okay, awesome. Linda and Dana, are you all good?
I'm good.
I'm good.
Okay, awesome. Very good. Then let's go ahead and make it the 17th.
I just sent the update.
Okay, very good. All right, if we don't have any further, well, let me ask, does anybody have any further business to go forward for the TAC this particular month?
Did you need a motion to go ahead and present the update to the back?
Present the update. Oh, that's.
You don't have to vote on the, all the TACs give a brief update. You only have to vote if there are recommendations you want to present to the MAC.
I'm glad you clarified that because the last 2 months I've said stuff, but there hasn't been any formal recommendations. So thanks for keeping me honest. Okay. So again, next meeting, August 20th, except for the special call on the 17th. Can we get a motion to adjourn?
So moved.
Second, anybody?
Second.
Okay, the second from Linda or Jacob.
Either one.
All in favor?
Aye.
Opposed? All right, very good. We're adjourned. Thank you all very much for attending today. I greatly appreciate everybody's willingness to be able to participate in the conversation. And I look forward to us speaking again on the 17th on the special call meeting. Thank you all very much.
Thank you all. Have a
Thanks,
good-
everybody.
Bye-bye.
Thank you, guys. Thanks, Keith.